Okay, so our next symposium is on robotic surgery. Very topical, very new, and I'm really interested to hear from our contributors during this session. I believe all the contributors are doing this online, but I'm going to introduce firstly Dr. Munikrishnan on the feasibility of robotic surgery in a developing economy. Oh, you're here. Oh, fantastic. Thank you. Well, welcome, and we look forward to your presentation.
Good afternoon. Thank you, College of Surgeons Sri Lanka and Edinburgh College for inviting me to speak on experience with robotics and how to make it work in this part of the world. So the topic I've been given is to look at the feasibility of robotic surgery in a developing country. Now that's interesting because what is a developing country? COVID just showed us the whole world is a big developing country. We all have challenges. And health economics has completely gone for a 6 because money is very important for every economy. And running a program or using a technology, it all boils down to how efficient and cost effective any program is. And I think that's very important across the world. I remember when I was training in the UK, the bosses list used to run any procedure. They had a set, equipment, instruments, sutures, everything was on the table, whether we used it or not. By the time I finished training, all that had changed. And now fast forward to 2022, I think it'll change even further because cost effectiveness is so important. So looking at adoption of robotics, there is an explosion of this technology around the world. As you can see, this slide which shows that there was a little lull when COVID hit, but post that there is constant growth and there is increasingly installation of multiple systems, different systems across the world. If you look at this slide which came out of Chicago, the introduction of robotics before hospitals adopt robotic surgery, and on the right is after hospital adopt robotic surgery. You can see that there is a slow but steady rise of use of robotics, and there is a decrease in open surgery, and also a lull in laparoscopic surgery. And this slide again shows that with time, there is a slow and steady uptake of robotics and more conversion to MIS techniques. This is a data from Intuitive. Even 2021, post-COVID, they had the numbers are there to see. There is there's so many new systems installed, 1,300 in 2021 around the world. Lots of work being done. As you can see in this worldwide procedure trend from Intuitive, there is, in 2020, you could see the red dot, that's effect of COVID. There was some plateauing, but post-COVID, 2021, 2022, there is a 15 to 30% growth being seen. Looking at the DV footprint in the subcontinent, particularly in India, you see in 2020, compared to 2012 to 2018, there is a mushrooming of robotic systems around the country. And with new players such as Medtronic and CMR coming into play, there are more systems, but this is just the DV footprint. The robotic procedure growth in the subcontinent, particularly in India, has been constant, steady, more general surgery, more colorectal. The initial impetus came from urology, but more and more oncology, general surgery is being done. Procedure, specialty-wise, most of it is urology, but more general surgery, head and neck, gynecology, thoracics, cardiac are all coming into play. Looking at the CMR surgical robot, which has been around now, and there have been more and more installations around the world, particularly in India. Medtronic has got a CE mark recently for general surgery in Europe. So they should be starting colorectal procedures. Urology is already there. And we've had 2 installations in India. So how do we leverage robotic surgery technology for better outcomes? Because that's what we're trying to achieve across the world, and particularly in newer countries. So the benefits of robotic surgery are all there. It's because you have better vision, it's more precise, less pain, smaller cuts, fewer surgical complications. We'll come to that, we'll touch on that. There's what we mean by that, reduced need of hospital stay and shorter recovery time. And for the surgeon itself, there's an enhanced visual field, there is better dexterity, better access to areas of concern, for example, deep in the pelvis, being a colorectal surgeon, I find it extremely useful. So I'm going to use more examples with colorectal surgery where we've been using it for the last 6 to 7 years. We know that there are several challenges for particular rectal cancer, where the tumor is, obese patients, narrow male pelvis, post-chemo radiotherapy, and if it's locally advanced or stuck to local structures such as a prostate. And we know there are challenges to TME or laparoscopic surgery, in particular obese patients, narrow pelvis, bulky tumors, post-chemo rad. And we see that very often in the subcontinent compared to the Western screen-detected tumors. Our tumors are larger. They pretty much occupy the entire pelvis often. Post-chemo, they're more advanced. And so it's a completely different beast. And conversion rates with laparoscopic TME. We know that there are several advantages. I think that in the course of this symposium, a lot of it will be addressed, but 3-dimensional views, 10 times magnification, better ergonomics for the surgeon, because that's not been really addressed in all the papers which have come in. What does it mean to the surgeon itself? I think that's where more work needs to be done, articulated instruments, and of course, camera and one assistant arm instrument under surgeon's control. All these are several advantages. But looking at the challenges itself in setting up an effective program, particularly in the subcontinent, it's been that to be cost effective, we need to know there is real value in using robotics. There's only one randomized controlled trial which has been published, which was done some time ago, called the Rollout trial, which pretty much nailed robotic surgery for rectal cancer, basically said. But when it was done, their endpoint was conversion to open. So they did not show any big difference between laparoscopic surgery and robotic surgery. And so that has been often quoted, and it's very, and it's a big challenge. But if you look, there's constant work being done, lots of papers being produced, mostly retrospective reviews, and some prospective studies as well, which I'm just summarized it because we want to time. Basically, as we stand at this point in time, compared to laparoscopic surgery, robotic surgery has got longer operative time, similar oncological outcomes, shorter length of stay, lower risk of conversion to open. As in rectal cancer, laparoscopy has a 14% conversion rate, and robotics is about 6.5% to 7%, and a higher cost. This is the current evidence. Now, but there are several advantages which you can leverage. One is, apart from all the advantages I've already spoken about, ICG fluorescence, particularly when you're using this advanced technology, which comes with robotics, to improving safety, reducing the anastomotic leak rates, to identify ureters, particularly when you're doing difficult operations, such as, say, diverticulitis or a advanced cancer which is stuck. Identifying small liver lesions, identifying lymph nodes outside the resectional margins, peritoneal mets. So ICG has been shown to help with all of these things, and helping with that eventually will show improving cancer outcomes and improved outcomes for the patient. Now, other benefits of robotics are, these systems come with data analytics. For example, this is a screenshot from my Intuitive app. So every time I do a procedure, all that data goes into the cloud and to my app, and I can see how many procedures I've done. Most of them are LARs, 256 in the last 5 years. It also shows how much time I've taken from, you can see that blue trend mark, which shows that there is the time comes down, or the procedure time comes down with more experience. And it also shows how many instruments I've used, what is the percentage of instrument use, lots of useful information for the surgeon and the hospital ecosystem, so that to know what your surgeons are up to. Similarly, Medtronic has introduced something called Touch Surgery. It was a UK company which was taken over by Medtronic. Again, data analytics. As soon as I finish the procedure, by the time I'm out of the operating room to my clinic, this whole video is uploaded onto the cloud, which I can see what I've done, show it to the patient's family, look at all my movements. I can learn from it, annotate it, share it with my colleagues. So this is all, that's where the advancements are happening. That's what's going to be very useful, when we look at advancing technology and robotics. Again, CMR has got Versus Connect. That's an, again, analytics platform which will help surgeons again. Now, surgeon ergonomics is something which I said has not been touched. It's very important compared to, we've done open surgery all our lives, and point to make is that we need to know how to do open surgery, then we MIS, and then technology. So all that is important, starts from there. But we've not really addressed what effect it has of standing long periods of time, long procedures over a surgeon's career. Now, with robotics having, where you can comfortably sit and do your procedures, I think there are some papers which have come out to show that it's better ergonomically, but more work needs to be done here. But I would rather have, comfortably sit, ergonomically comfortable, and do my procedure rather than stand 4 or 5 hours and do an anterior section. So, several advantages. More data is evolving, but how do we actually set up a robotic program? So these are the challenges we faced when we set it up 6 years ago for colorectal surgery. So the main issue was cost benefit and surgeon training credentialing. Looking at cost benefit analysis in robotic surgery, there are several things to look at. One is the capital acquisition costs, equipment maintenance costs, instrumentation, operating room time, operating time, complication of conversion rates, length of stay, ergonomics, and robotic assist system benefits to surgeon. So if we clump the capital acquisition, equipment maintenance cost, and instrumentation all together, let's look at that. The cost of a robotic system approximately $2 million. Now, that, I think, initial cost is the biggest challenge anywhere around the world, particularly in the subcontinent, and that will freak people out, health systems, to say, where am I going to find the $2 million? But we need to look at as an investment like a operating room, and there is an early maintenance of 10% of yearly of the base cost. Now, factors which affect acquisition are the market demand. There's research which shows that basically if patients will ask for it, one. Two, and if there is no robotics, hospital systems have shown to show interest to be a front runner in that space rather than, there are multiple systems and I'm going to compete with that. So market demand and available resources are important. So what we need to balance is that the patients will demand, and any adoption of new technology is seen as high quality care. So patients will come and say, look, do you do robotics? If not now, tomorrow, in a few years, they will come and ask, or they will go somewhere where it's provided. So the hospitals have to balance the acquisition operational costs with the patient demand and adoption of new technology. Instrumentation, again, instrumentation use varies with procedures and surgeons. As of now, limited number of uses per instrument independent of wear and tear. So for Intuitive, it gives 10 uses per, 10 uses, screen's missing, guys. 10 uses per instrument. Now, there are new models of instrument usage coming in. There are robotic companies which say we will package the instruments into one procedure. So for a cholecystectomy or a LAR, there are 10 instruments, you pay a fixed cost. There is also some companies are putting forward time-limited cost, fixed costs, where say a needle driver has got a 1 hour or 2 hour functionality. So you can use it for 3 different patients or 4 different patients. So as new systems come into play, all these packages will be offered by these companies, which is going to benefit us. The good news is robotics is here to stay. I would say it's a good news, and it's going to get cheaper because definitely as technology evolves and more choices are available, and also these instruments will become reusable. And there are several companies who are trying to use non-restricted instrumentation to the robotic system to perform less technical maneuvers. For example, to retract something, you may need a restricted instrument to throw a knot or to do dissection around a vessel, but to retract something, you don't need a restricted instrument. You can use a 2-dimensional instrument like a laparoscopic instrument. So that's ClickLine, which is being played around with Medtronic, which will come. So you can mix and match that. It's coming. So what I'm trying to say is, as this presentation goes and as you think about it, don't think, oh, it's expensive. Think about how am I going to make it work and what is going to happen in the future. Otherwise, we'll be left behind for 10, 20 years, and there's lots of people doing different things, exciting things, and I think got to constantly think about those things. Now, coming more specifically, achieving improved outcomes and theatre efficiency in this environment while setting up a program, there are three main things which we need to look at. One is surgeon training and specialization. Second is team training. And third is theatre efficiency and procedure time. And this is more of our learnings, what we've done. So surgeon training and credentialing, I think whatever technology you use, lab, robotic, open, you need to know how to do an anterior section. It does not matter, if you have an autonomous robot too, which will come, I'm worried. But a surgeon needs to know the anatomy, physiology, primarily, and know how to do an operation. Until you know that, technology is just an adjunct to it. Please, that's for the juniors in here, know your basics. That's so important. You need to know how the basics general surgical training. You can go into subspecialization, colorectal, hepatobiliary, pancreas, whichever you fancy, but you need to know that. And then comes your fellowship in specialty, and then your robotic specific or minimally invasive specific specialty training. It's so important to drive that because a lot of surgeons, young people who come and watch and say, oh, wow, look at this technology, and I'm going to jump straight into it. It doesn't work like that. It's taken years and years of learning the open, then lap, and then probably robotic. And of course, there is evidence where you can jump straight from open to robotic. The learning curve is smaller. That will come to a bit later, and it's outside the remit of this presentation. And subspecialization, in particular rectal cancer, we've seen that there's lots and lots of data over decades showing the more you do, the better you get at it. That's why it's so important to do more of a particular organ-specific surgery. There's a lot of evidence saying that lower morbidity, lower postoperative mortality and recurrence. And if you're, for example, colorectal trained, you would do more resectional and reconstructive surgery rather than a end stoma procedure for rectal cancer. So more subspecialization is good when you're building a program, and because with subspecialization, your outcomes are good. With subspecialization, there is increased volumes. With increased volumes, you get good at it, your skill sets are better, and you have better outcomes. And that's ultimately what we are all working for, better outcomes for our patients. So once we have that subspecialization component and you're building your volumes, then you need your surgeons to need to be trained. There are several ways to do it. Compared to 20, 30 years ago, there's e-learning is very well established. The Edinburgh College, for example, does amazing work in our e-learning programs, and I'm sure a lot of our trainees would have seen that. There is increased awareness of benefits of e-learning across healthcare. And there's lots of standardization as well. And also non-technical skills learning, because there is focus on the newer robotic curricula to look at error identification, crisis management, because those are important things which we've noticed. A lot of the time we panic, and how to avoid panic, particularly when you're using advanced technology. And so those have been incorporated into the robotic non-technical skills curricula. Simulation training has been around from 600 BC in the subcontinent. And so we have several platforms to do that. There are animal platforms that are low cost. Facility is required, obviously, deceased or alive. And it can replicate real case. Human cadaver is the gold standard for anatomic training. Both training types are high cost. There is legal requirements, single use. During pre-clinical simulation-based training, real-life case observation in a training center is very useful. Looking at robotic preclinical simulation-based training, there's several platforms available. Most of the companies or tech, including CMR, Intuitive, Medtronic, provide simulators which will give you that training, which trainees can do in the off-peak hours, get that simulation training done. Console training, there's online modules available which you need to go through, pass those or do those tests before you embark on actual certification. And then they're pretty much established, and all that data is available online. And then there's patients, once you cross to the online training and then the simulation, then you get to patient Bedside training exposes training to the console and the bedside, necessary developments unique to assistant training, troubleshooting, keeping the arms without clashing. These are all very important. Ergonomics, because once you have a good assistant, the operation, as in any open lab or robotic, it's much easier. And even with robotics, you still need a good bedside assistant to sort of oversee that smooth running of the operation. I'm going to skip a couple of slides. And then, important question, is lab experience important? A lot of people question that. In our experience, we find that basic lab skills are required because, a lot of people use a lab stack to gain access and then use the robotic system. Again, there is cost involved here because there is sterilization of the lab system, then the robotic system. You could use the robotic camera to do initial laparoscopy, create a pneumoperitoneum, take down the adhesions that prevent port insertion, application of clips, suction, retraction. All that comes from basic laparoscopic skills. So I think it will augment your uptake of robotics, and I think it will make you a safer surgeon. So I would say more MIS, better, always. So looking into more specific training, for example, LAR, you, like any procedure, break it down to steps, and with the proctor, you can do the vessels or medial to lateral dissection, or modular console training, as we call it, and then move on to full procedural training, which is a natural process. And of course, there is telementor with technology, 5G coming in, another area which we can, with enhanced feedback for trainees through telementoring. Prof. Lacey from Barcelona has been doing quite a bit on this, using his AIS platforms, where you can, be online and, connect to the robotic system far away and do telementoring to help with the procedure or training with the procedure. So we do have training pathways primarily developed by the urologists, and we are adopting it for general surgery, thoracics, cardiac, baseline evaluation, e-learning, simulation, modular console training, and then a full procedural training, final evaluation, feedback with gas forms, and then training the trainers as we do for any procedure. Team training is very important. But we found that having two teams, one the bedside team, one console surgeon team, and you clearly give them instructions what they have to do. The console team being the main surgeon, proctor, responsible for robotic dissection. The bedside team is the main assistant. Trainees are there, scrub nurses. They're responsible for port positioning, retraction, stapling, specimen extraction, and anastomosis. So once you set this up, and it becomes like a beautiful orchestra, and it becomes a much safer operation. Significant benefits, the procedure becomes faster and clearly defined roles. So theater efficiency is important. We've been able to start our procedures very early on. If you're, further in the learning curve and you've done some procedures, we try to do it as, in our unit, the first case in the morning, with 5:30, even before anyone comes in, you're there, patient is positioned. By 9:30, 10, the hospital starts to roll, procedures done, and we can get into our outpatients. We found that extremely useful. It is hard some days, but you get into a routine as long as you find the theater staff, nurses to help them. But that's where the commitment and programming comes with, developing that system. And I think we found it extremely useful. So what we do is to try to start the procedure first thing in the morning. It's quiet, it's peaceful, and you can take your time to do when you're starting the procedure. Try to do with the lap stacks, use the camera from the robot. It's lighter compared to the older systems. The newer cameras are much lighter. So you can use it to put the ports in, take the adhesions down. We don't drape the robot because even the drapes cost. So if there is, for some reason, there is metastatic disease or a lot of adhesions not feasible to do robotically, then you can save on even the drapes. So they are all ready. Then there will be a nurse ready to drape the robot. Once we know that we're going to progress, we drape it within a few minutes. And all these little things matter. And then standardize your procedure. Break it down to 4 different beats. And if you're subspecialized and you do, for example, just rectal cancers, you know what your first 10 steps are going to be. And your team knows it. And it works like, it becomes very industrial. So that's what we do. If everything okay, we drape the arms. When we started the program, we didn't use the 4th arm. Each instrument is, say 250 pounds or $300, $400. We wanted to use the instrument, the wristed instruments for rectal resection. That's what it used for. For retraction, I could use a laparoscopic instrument. So that way we save on money. So because the initial challenge was cost, and the program was stuttering. So we said, okay, let's strip it down. We call it strip down robotics. Go down to the basics and use the two arms for what it's designed for, to do complex maneuvers. So use the two arms, do that. The fourth arm can be tucked away. If there is, cost is not an issue, use the fourth arm by all means. Because of going back to training, which was amazing in the UK, which I received. And once you know your procedure and you were subspecialized, your need for energy devices also comes down. So we routinely never use an energy device for a TME, for example. We just use monopolar and bipolar grasper. Again, every instrument adds to the cost. So you can strip it down to very basics and then add on as you want. Because as I said, you want to make your program up and running and then deal with other challenges. So, and we use air seal routinely. Prof. Lacey introduced me to it, particularly low in the pelvis when you can't see, gets fogged often. Air seal maintains the pneumoperitoneum and doesn't fog as much. So I'm just going to fast forward this. So standardization is the key to success of any program. Cost efficiency. Looking at our data, we were able to achieve very low anastomotic lakes. This is data compared to the NESQIP data published in the US comparing open lap and robotic. Let us stay slightly higher compared to the NESQIP data because our patients come from out of town and they tend to stay in hospital before they go. But otherwise, our readmission rates are 2% compared to 20% in the US NESQIP data. Our wound infection rates are 1.4%, 1% anastomotic leak rates. We also found that compared to our first 75 cases and second 75 cases, the consult time comes down and the cost comes down as well. So that's data. And the good news is there are several new players coming into the market, CMR, Verb Surgical, Medtronic. Cost will go down as much as 1/3 to 1/2. So, and also even the main player cost will also come down, or they will offer more benefits, additional extra instrument usage, for example. And so for a robotic program to be for example, Intuitive, to be cost effective, you need to be doing about 400 to 450 procedures every year in your hospital. So expecting me to do 450 procedures is impossible. So the best way to have a successful program is to do a multi-specialty use, gynecology, urology, thoracics, upper GI, general surgery, and so cardiac. So it will mean more volumes, lesser per patient cost, and you will have a good, vibrant, cost-effective program. And so with efficiency, quality, and speed, your costs will come down. And in conclusion, the robotic surgery evolving, there's increasing adoption, more data is required, improving outcomes and conversion rates, anatomical safety with ICG type technology, quicker recovery, data analytics are useful, surgeon economics are better. Newer robots and robot-assist technology will drive down costs. Surgeon training is critical. Small cost efficiency steps will add to make an impact for better adoption and feasibility of robotic programs wherever in the world, particularly in the subcontinent. Thank you very much.
Thank you, Venki, on that shedding light on the feasibility of robotic surgery in this part of the world. And our next speaker will be joining from India, and that is Dr. Narasimhaiah Srinivasaiah, and I think he is online. Yeah, okay. Dr. Srinivasaiah is a laparoscopic and robotic surgeon at Apollo Hospitals, and he established and heads the Apollo Institute of Colorectal Surgery in Bangalore and leads Apollo Institute of Laparoscopic and Robotic Colorectal Surgery as well. Over to Dr. Srinivasaiah.
Honorable Chairman, delegates in Sri Lanka, my fellow colleagues online. A very good afternoon. Like they say, Shubha Sandhyavak in Sinhalese, although my Sinhalese is not that great, and Vanakkam in Tamil. First of all, my heartfelt thanks to Pramod Chandrasinghe, who's been my colleague and contemporary at St. Mark's, and I truly appreciate the opportunity to share my thoughts on robotic colorectal surgery, training, numbers, and the learning curve. I will try and share my screen so that I can get on with the presentation. Thank you. There's a nice saying that goes, a fool with the best tool is still a fool. I think technology has to be utilized responsibly. And what should not be forgotten is the touch that goes with the technology. Training is an integral part of technology, and I think that is one of the key factors when it comes to robotic colorectal surgery. The next few minutes, I'm just going to touch on some amount of evidence base, a bit of an orientation to the technology, so to say. When robotics came into play, we probably call it as the Mona Lisa of surgical technology. Surgery is an art. I think the technology has provided us with the precision, the depth, range of movements, vision, and of course, it comes with a cost, needless to say. I don't need to get into the nitty-gritty of the complexity of the robot itself, but what you need to understand, realize is, we need to know our tool. If you do not understand the technology and the tools, I think it becomes difficult for one to progress on the clinical side. I think majority of getting to know the technology has to be driven by yourself and the company which is helping you out. I think the downside of laparoscopy, the difficulties we face with the laparoscopy were to a great extent corrected by robotics, and hence robotics has certainly fared well compared to laparoscopy. Venki has spoken extensively about robotics, comparing it with open and laparoscopy. But I think going for a methodical modular approach, understanding the placement of the ports, the targeting the area, the surgical zone, all these little things will certainly play a huge role in undertaking robotic surgery. An important aspect is to place the robot on the patient, the docking, and it can be methodically done in a quicker time once you are used to it, not more than 5 to 10 minutes. Modular approach is truly the answer to good training, broken down into various steps. I think one can master the whole procedure in a stepwise fashion. I'm going to briefly touch on my training and touch on the current training pattern in India. I'm ever so grateful to Professor Amjad Pervez, who heads the European Academy of Robotic Colorectal Surgery, which is where I gathered some amount of training. A very structured program, modular based, assessment based, and eventually assessing you and signing you off is what they follow in the European Association of Robotic Colorectal Surgery. Compared to what we are currently going through as a part of industry-driven training here in India now, I'm being blessed that I've had the best of both the worlds. A European training certainly was not without difficulties and was not an easy task. It took me moving from Britain to Portugal for almost about 4 months to get the training what I needed, from console training to cadaveric laboratories to spending time in the unit learning the nuances of robotic colorectal surgery, assisting them, doing independent procedures proctored by somebody senior, sending the videos back to them, doing the gas forms, and eventually getting signed off. So I think it was a process, least to say. The sudden expansion of robotics in a country like India, which is commercially driven, which is a capitalist country when it comes to healthcare, is predominantly and unfortunately driven to a great extent by the industry. The industry has got a training pathway recommended, but what they do not vouch for is, they do not say, we can guarantee you the clinical outcomes. They guarantee you the technology, but they do not guarantee you the clinical outcomes and the accreditation, which relies entirely on the clinical fraternity. So this slide essentially shows some amount of industry-driven interest and industry-driven initiative about introduction to intuitive technology. It also helps us with online modular training, in-service training, and there are assessments. But are these done religiously, objectively, is something to think about, and it is something to question ourselves. At least in the part where I am, I don't think it is done that objectively and to a greater depth, is my thought process. Moving on from there, there's an initial case series plan, where again we say you have to assist in a procedure when it comes to technology skills development. How much can we leave in a procedure? Something to think about. And it's all very objective. It's all very subjective, and there is no objectivity attached to it. Perform a procedure. How many? Complete a technology skills drill session, okay? And skill simulator session if one is available. So there is a lot of gray area out here without a definitive objective pattern attached to it, something to think about. And with a continuing development, there is a peer-to-peer learning, watching some videos, and eventually you're signed off. And if one can do this in a very quick manner, in about 3 to 5 days time, you can be certified if one is truly up to it. But is that what we are looking for? Does that give you enough skill, expertise, and knowledge to go on a robot, is something to think about. So this is what intuitive gives the moment you finish your online training. And a typical training pathway for robotic colorectal surgery, which has been revolutionized by the European Academy of Robotic Colorectal Surgery, takes you through a lot of training modules in a stepwise manner, progressing from one to other. So they talk about at least 20 to 25 cases that has to be done, supervised, to be followed by, direct supervision, associated with assessments, in addition to MCQ assessments and video assessments that are actually anonymized and sent for, assessment. So this is the sort of training that one goes through, at least in the European setup. One of the reasons for people not taking up robotic training in India is the lack of confidence. Once you have gone through the hardship, and taking you through all this certainly gives you that confidence. And knowing your tool is the most important confidence factor, I think. And if you spend less time on it, I think the confidence levels are certainly lesser. There is no question about the personal training attributes. Motivation is the key. Personal interest and persistence, perseverance is very vital. Technological know-how, knowing whichever robotic system you're using, is very, very important. I think there has to be an enormous amount of support from the institution where you're in, and no doubt the industry's interest that they train you so that you can utilize more of the robot, so to say. And the government, the policymakers, and the insurance people truly have to help out in bringing robotics to the next level. Venki has spoken enough about the volumes. The more we do, the better it is. There is a touch of evidence talking about what are the learning curves. How quickly can one become proficient in a robotic colorectal surgery or robotic assisted surgery? The conclusion from the systematic review is, it is very difficult to say, because the studies that have been undertaken do not fit the eligibility criteria with a lot of flaws in these studies. So essentially what they go on and say is, it is a difficult one to say that this is the exact number we need. But there are other studies which look at the learning curves in colorectal surgery. And especially for those people who have been doing already minimally invasive surgery, such as laparoscopy. So the rough number goes around 25 to 30. And this is the rough number which has been talked about by when your conversion rates come down, by when your complication rates, so to say, the Clavin-Dindo complication rates come down. But when we add the marginal gains into the whole picture, when you're proctored through a structured training program, I think this number comes down. That again comes from some data that comes from Erlangen, which is actually not here. But what, not Erlangen, apologies, from Champollion Foundation in Lisbon, which talks about a structured training program. When done in a methodical, proctored way, it's about 10 to 12 cases is what one needs if done in a methodical way. What they really looked at was, when they looked at these trainees who went through the European Academy of Robotic Colorectal Surgery program, after about 10 cases, the risk of conversion comes down. So they thought 10 to 12 cases was something to look at. And they also looked at the Clavin-Dindo 3 to 5 complications. And even when they looked at that, they said it's roughly about 10 to 12 cases, absolutely proctored in a modular approach that one could reduce the number of significant complications, so to say, when it comes to robotic colorectal surgery. So ladies and gentlemen, I think robotic colorectal surgery is here to stay. Technology is something that we're gonna see much more. You cannot run away from technology. Training is a very vital aspect of technology, getting to know the technology and not to forget the touch that should be associated with technology. Learning curves are important. Going through a methodical modular approach is very, very vital. And let us not forget, we're not actually treating the cancers, but we are treating patients with cancers. So let us see the person who is harboring the cancer and treat them. And as we all know, decisions are the most difficult things to take. Decisions are difficult than incisions. And it is something that we have to keep in mind, taking into account the multidisciplinary teams. And let us see that there's a person out there who harbors a cancer, who needs to be treated, and it is just not the cancer. Thank you. Thank you for your attention.
Yeah. Our next speaker is Dr. Roy Patankar. He's also joining us remotely. And Roy Patankar, let me introduce Dr. Roy Patankar. Roy Patankar, MS, MBBS, MS, FRCS. He has presented more than 100 scientific papers at various national and international conferences, and delivered guest lectures at more than 150 conferences. And he has more than 40 publications, national and international, and several book chapters to his credit. And his main interest is laparoscopic surgery, functional colorectal surgery, and robotic surgery. Without taking much time, Roy is going to enlighten us on medical advancements made feasible in developing world. Over to you, Roy. Can you hear us?
Yes, I can.
Thanks.
Hello? Can you speak a little loudly? Can't hear you.
Yes, Roy, we can hear you.
Wonderful.
Okay.
You want me to start?
Yes, yes. Yes,
Great.
please.
Can you see my slides, Sumudhu?
We can see your slides.
And my audio is clear to you?
Yes, very clear.
Wonderful. Thank you, Sumudhu and the College of Surgeons of Sri Lanka. I think it's my misfortune that I couldn't come to Colombo. I have some very fond memories of some wonderful meals I've had in Colombo, and the poolside drinks the Sumudhu offered me the last time I came. I think this is going to be about, I think you had some wonderful talks by Dr. Narasimhaiah as well as by Venki, my friend. And this is how surgery has evolved with time, from freehand surgery to minimal invasive to robotic assisted, and eventually I believe we will have surgery with full automation. I think I remember my journey in minimal access surgery in 1990 when I went to England, and this is early days, and I'm sure I'm following the same learning curve now that I'm in robotic surgery. A surgeon's growth path often depends on whether he chooses the avenue of soothing applause or the trail of prickly criticism. I remember as a fellow, when I was leaving India to work in England, people said, you know, there's no future in laparoscopic surgery. Stick to open surgery, you'll do well in. I think the question is now being raised about robotic surgery, and you have heard the previous two speakers talk about robotics. Wonderful. As a surgeon, you need knowledge, skills, and competence. This is a famous management slide. This is a municipality in the country of Peru who built a bridge not realizing that the river was changing course. So you need to have your ears close to the ground, see where technology is going, see how technology can be adapted to your patients in your home country with those conditions. So this is how the transition, this is a pelvic lymph node dissection, lap, and then robotic. I think pretty much achieved the same thing, but I think this has been a natural evolution in my journey as a surgeon from open to robotic surgery. As Lord Moynihan said, the cleaner and gentler the act of the operation, the less the patient suffers. The smoother and quicker is convalescence, and more exquisite is healed wound. We all know the advantages and disadvantages of laparoscopic surgery. Robotic surgery has its own advantages and disadvantages. Certainly wonderful visualization, particularly in the pelvis when you're doing a low AR, as Venki said, or doing achilles. I do a lot of esophageal surgeries with it. It gives you a great 7 degrees of freedom, but there is a loss of haptic sensation, and there is a steep learning curve. And I think the learning curve is much as I had in minimal access surgery. We have many new robots coming. I have been using the CMR robot that you see in the center for now about 4 months. I looked at the market very carefully, but I'll come to that in a minute. As Venki said, the way of making this cost effective, in my hospital, we have oncosurgery, we have thyroid, we have me doing GI, we have a very busy urologist, and we also do some thoracic work with the robot. When you get a new problem, these are the common things that I hear senior surgeons say. I don't think this is relevant to me in my country. Robotics is not needed. My team is not trained, it's expensive, and I don't have time. I have a lot of clinical work. I just don't have time to learn these newfangled things. I think new technology is here to stay, ladies and gentlemen. And as Professor Narasimhaiah said, a fool with a tool still remains a fool. I looked very carefully at 4 robots: the Da Vinci, the Medtronic Hugo. There is a new kid on the block called the Mantra robot, and finally the CMR. So as a surgeon who wanted to acquire a robot and wanted to acquire a new skill, I wanted a robot that would work across surgical specialties, would have high usage, would necessarily be small and mobile. And we have 5 theaters on 1 floor, and I wanted a robot which could be moved from OR to OR without delaying my lists. This is what our robot looks like. It has 4 separate arms, which are extremely mobile. And typically, as I'm finishing one case and the patient is being extubated, the entire system is moved into the next OT, and my next patient is intubated. I begin the next robotic surgery before the first one is shifted out. So there are advantages and disadvantages, but I am personally convinced that the future of robotics is going to be modular arms. And I know for a fact that many new robots that are being developed or that are coming in the market will have an open surgical console and will have modular arms. Ladies and gentlemen, most of us like to work in the comfort zone. We tend to find excuses, be affected by others' opinions, and often lack self-confidence, as my previous speaker said. For you to grow as a surgeon, you need to go into your learning zone, dealing with challenges, problems, acquiring new skills, and extend your comfort zone, and that's where you will be. I deliberately putting on a video of my first robotic lap chole, which was about 5 months ago. This is me sitting at the console. It's open console. I have two trainees sitting next to me. The one on my left is Professor Avinash Supe, who is my teacher. And we have people who are watching a 2D screen on the OT, and this is how the robot is done. The anesthetist, as usual, is busy on his mobile phone, showing that everything is well with the patient. But this is how a robotic, and we started by doing 5 robotic lap choles and 5 robotic taps. And our average time is about 35, 40 minutes, and that shrunk even further. Just to show you how that is. What I realized that training is extremely crucial because there is a lack of tactile feel and a haptic feedback. Special problems linked to robotics include clearance, we have restricted movements, and we need to build a team in the OT. Like in laparoscopic surgery, you need a good camera person. You need to have a separate bedside team, as Venki said, who will be adept at handling instruments and taking care. Jugaad is an Indian word, which means make do. And I'll give you some of the examples of Jugaad that we learn. I learned some of this from Dr. Palani Velu in Coimbatore, who's been one of my teachers and mentors. But we do various things. We actually divide the falciform ligament and use it for retraction. Basically, I work with 3 arms. The beauty of the CMR is they don't bill you by instrument, they bill you by procedure. Instrument, if I use 5 instruments, that's fine. But I usually land up using 1 visual bedside unit and 2 working arms. And I use these small techniques like dividing the falciform, lifting it. I put little rubber bands. I stitch a rubber band on the mesentery of the bowel and use the rubber band with a suture passer to actually lift the bowel up, as you can see. And that actually makes it very easy. To do a LAR, I routinely put a stitch. And what I do in this is I drive a spinal needle through the dome of the uterus and feed in a 2,0-ethylon and lift up the uterus. We can sometimes in sigmoid colectomies, I put an umbilical tape around the sigmoid colon and give it to my assistant with a suture passer, and he lifts the colon for me. I don't think there is much controversy about the effectiveness of robotic surgery in prostate cancer. It's a given. I think increasingly most cancer prostate in India is done robotically, but there is also emerging data on rectal cancer. The short-term outcomes, the nerve preservation is perhaps better, and this is gradually now getting more and more data coming on other GI cancers, perioperative outcomes and oncological safety not being compromised. Be it the lower GI is very well established. I think doing a low AR in an obese man like me with a narrow pelvis is a challenge for the best of surgeons, but the robot gives you a 3D vision inside the pelvis and makes it easy. I see one of the topics was the cost effectiveness in a developing country. I think in South Asia, be it Sri Lanka, India, Nepal, Pakistan, we have similar problems. I wear 2 hats. I'm a passionate GI surgeon. I'm also an entrepreneur. I employ about 500 people in 2 hospitals with 200 beds. For me, return on investment, the EBITDA is extremely important. And I need to choose a robotic system that would at least break even in the first year, if not make money. Is it FOMO? Is it fear of missing out? Perhaps yes. I was on the laparoscopic bandwagon in 1991, and I think if we get trained in this generation of robots, I think in the years to come, we will have increasing artificial intelligence, we'll have autonomous robotic surgery, and I think you want to be trained in basic robotic surgery before these new exciting technologies come. We are a busy GI center. We have 5 fellows and residents every year. I think I can't run a busy GI center without doing robotics. Yes, it does have a mark. I think this may not be true for government surgeons in Sri Lanka, but those of you who are in private hospitals, we do attract a lot of work because of our robotic labor. Also, finally, I'm getting old. I think sitting at a console, not with my eyes glued to the console, but sitting away, I have 2 trainees or 2 fellows sitting next to me, you wearing 3D glasses, makes my life really simple. So I'll quickly show you, 2 robotic, 2 robotic videos. And I think the beauty of this is, so this is a radical nephrectomy I did yesterday. And this was a 10 centimeter polar tumor. And you can see the robotic hands going in. And pardon me, this was a case I did yesterday evening, so I've not had much time to actually edit the video. I'll run through the video just to give you an idea how it works. The beauty is, it was densely adherent to the spleen, the upper pole. We wanted to do a renal preserving nephrectomy, and even larger, it's very good for partial nephrectomies. We have a fair amount of experience with partial nephrectomies, but I think this is a good system, not only for colorectal surgery, like my two previous speakers, but
Roy,
because I do all of
seeing
GI
the
surgery.
video.
We can't see the video at the minute, Roy. Sorry.
You can't see the video? Okay. Can you see it now?
Yes, that's good. Thank you.
Great. I'll just take it back. I think this is a 10 centimeter polar tumor, and you can see I'm using a CMR robot. I have in my left hand a grasper and a right hand a bipolar Maryland. We have one harmonic in the other. I'm just going to quickly run through this video. This is I'm getting the pedicle exposed. So I think we do a fair amount of achalasias, fundoplications. Like I think for rectal cancer, it's a given. But apart from that, I think the whole of GI surgery, we do right hemicolectomies. This is a radical nephrectomy, particularly good when there is suturing. Like for a partial nephrectomy, it makes a sense where you can do very elegant suturing using a robot as compared to what you would do with laparoscopic surgery. This is the renal vein that's been isolated. The clip goes in. I'm just going to run this video briefly, just to give you a feel of what the robotic thing is like. The whole procedure took me 1 hour and 40 minutes, maybe 20 minutes longer than it would have taken me in robotics, but I am very much in my learning curve. I've only done 40 procedures in the last 2 months, and I'm sure as Venki has shown, my times will get shorter, it'll look much more elegant, and the blood loss will be less. I'll quickly now show you a video of achalasia. I have a lot of concerns about achalasia.
Roy,
Because I
I'm
felt that
sorry.
the haptics.
We are just about to start the next session.
Okay, I'll stop there then. Thank you. Thank you, Samudra. Thank you for inviting me. And it's my pleasure to have joined you.
Thank you very much, Roy. This concludes this session. And what is next?
Another keynote plenary session.
Okay, the next plenary session will start now.